Section 04 focuses on asystole and PEA, which are categorized as non-shockable rhythms. These conditions represent cardiac arrest scenarios where the heart's electrical activity is either absent or fails to produce a mechanical contraction, meaning a defibrillator shock will not help. Understanding these rhythms is critical for any advanced cardiovascular life support provider. We will examine the specific protocols for identification, the physiological challenges of electrical mechanical dissociation, and the pharmacological priorities required for resuscitation. Throughout this module, we will emphasize why these rhythms require a different approach than ventricular fibrillation, focusing heavily on high-quality CPR and the rapid administration of life-saving medications to restore spontaneous circulation. Asystole, often called a flatline, is the first non-shockable rhythm we must master. Verification is the mandatory first step, requiring you to confirm the rhythm in 2 separate leads to ensure it isn't actually fine ventricular fibrillation or simply a loose lead. Once confirmed, the treatment protocol dictates immediate CPR and the administration of epinephrine. It is vital to remember the instruction, do not shock. Delivering a shock to an asystolic heart provides no benefit and actually causes myocardial damage while interrupting the essential chest compressions needed to circulate oxygen. Your focus must remain on high-quality compressions and identifying any underlying causes that led to this total cessation of electrical activity. PEA, or pulseless electrical activity, presents a unique challenge where the concept is that the monitor shows an organized rhythm, such as sinus rhythm, bradycardia, or tachycardia, but the patient has no detectable pulse. The problem here is defined as electrical mechanical disassociation, where the heart's electrical signals are firing, but the muscle fails to respond with a physical contraction. For treatment, you must search for the H's and T's to identify the root cause. This condition is a mechanical failure, usually caused by an outside factor, such as severe blood loss or a collapsed lung, which prevents the heart from pumping effectively, despite the presence of electrical signals. The epinephrine priority is a cornerstone of managing non-shockable rhythms. Regarding timing, in asystole and PEA, epinephrine should be given as soon as possible, ideally within the first minutes of the arrest. The impact of this strategy is profound, as early administration of epinephrine is significantly associated with higher rates of ROSC, or return of spontaneous circulation, and overall survival. Unlike shockable rhythms where defibrillation takes precedence, in these cases, the vasoconstrictive properties of epinephrine are needed immediately to increase coronary perfusion pressure and restart the heart's mechanical function. Every minute of delay in giving this medication decreases the likelihood of a positive neurological outcome for the patient. Identifying reversible causes in PEA is the only way to achieve a successful recovery. Hypovolemia and tension pneumothorax are the most common causes of PEA and must be screened for immediately during resuscitation. If hypovolemia is suspected due to trauma or dehydration, the necessary intervention is to give a rapid fluid bolus to restore circulating volume. Conversely, if a tension pneumothorax is suspected based on physical signs like tracheal deviation or absent breath sounds, you must perform needle decompression. Addressing these mechanical obstructions or volume deficits is the only way to allow the heart to resume effective pumping, as medications alone cannot fix these structural and physiological emergencies. The termination of resuscitation is a difficult but necessary part of the protocol. The decision to stop is typically made when asystole persists despite full ACLS interventions and the correction of all reversible causes. Several factors influence this choice, including the total time elapsed from the arrest, at TCO2 levels after 20 minutes of high-quality CPR, and the nature of the initial rhythm. Finally, ethics play a major role. Providers must support the family through the transition from life-saving efforts to end-of-life care. This involves clear communication and ensuring that the final moments are handled with dignity, providing closure while acknowledging that all possible medical interventions were exhausted.